Okay, we're going to talk about the anti-arrhythmic drugs. It is one of the most challenging topics. So, okay, for this, we must know that when we give an anti-arrhythmic drug, we give it with one purpose. We want to get rid of an arrhythmia. But sometimes it is the case that this anti-arrhythmic drug has what is called pro-arrhythmic effects. Why does it happen? Okay, we have already studied the action potential in here. We could possibly summarize this action potential in this kind of trapezoidal shape. We could say that the action potential can be divided in these depolarization parts, which mainly depends on sodium here. Then we'll have this plateau phase, the one in here, that we know that mainly depends on calcium. And finally, we will have the repolarization phase here, that mainly depends on potassium. So when we give an anti-arrhythmic drug, we can try to have an effect rather in one of those three parts. The thing is that sometimes, for example, if we want to block the sodium channels, the drug also has an effect, for example, in the potassium channels. And those effects in the potassium channels are the ones that give us, for example, side effects or the pro-arrhythmic effects. So, knowing that, we are going to start the classification. We are going to use the classic classification that is called the Baugham-Williams classification. And it classifies the arrhythmic drugs in four. Summarize, the class 1 will mainly have the effect here in sodium. Class 2 and 4 will have the effect, class 2 and 4, they have the effect in calcium, and class 3 will have the effect in the potassium. As we know, for example, we can give a patient an antiarrhythmic drug of class 1 to block the sodium channels, but it could also have a little effect, for example, in the potassium channels, so it can give us any potential pro-arrhythmic effect. So, knowing that, we are going to start with the first class. There is the class 1. Class 1. So we know when we remember class 1, we must remember that here we are blocking these sodium channels. To talk about the class 1, we must talk about one concept before, that is the concept of use dependence. The concept of use dependence of a drug. It means that, for example, in the case of drugs that block the channels, of the cation channels here, for example, we can have channel here, and here's a channel, for example, and there is a drug that tries to block the channel. Okay, so the term of use dependence in that case will mean that the drug has more effect when we use the channel more. So it means that the more that this channel, it could be, for example, a sodium channel the more that this channel is used, the more effective the drug is. Why does it happen? Usually because this drug is very slow in the onset and offset. That means in attaching and detaching from the channel. And because it's very slow, when we are firing very fast, when we are using the channel very fast, it doesn't have time to attach and detach. So it is continually blocking the channel. So it means that the more that we use the channel, the more effective is the drug. So the more that it is blocking the channel. This is the term of use dependence. So when we have drugs that usually are very slow in their onset and offset, they have a high use dependence. If we give them, for example, for an arrhythmia that is firing at a very high pace, they will be more effective. So, knowing that, we can start with the classification. In the class 1 drugs, we have 3 types. There is class 1A, 1B, and 1.3. We are going to start from 1C, and you will see, because it's better for understanding. We're going to start from 1C, then 1B, and then 1A. Okay? So we remember class 1, we are blocking the sodium channels. We are going to start with class 1C. In class 1C, we have 2 examples. We have flecainide and propafenone. Yeah, okay. So in this case, we know that this is a drug that is very slow. We know that we have slow drugs, medium, and fast. Remember, the slow ones are the ones that have high use dependence. So in that case, these drugs are very slow. So that means that they have a high use dependence. It means that when we use this drug in a arrhythmia that is firing very fast, because they are blocking this sodium channel in this arrhythmia, the slope will decrease a lot. It will decrease a lot, this slope. And then the rest of the action potential will be more or less the same. They act just a little bit in the potassium channel, so they will increase, but not much, the repolarization, and it will be the main anti-arrhythmic effect. So we mainly use these drugs in arrhythmias in which we have a very high pace. They are firing very fast, so that's why we are using this in arrhythmias that has the origin in the atrium. For atrial arrhythmias, mainly atrial tachycardias, also atrial fibrillation, because atrial fibrillation usually have the onset on atrial ectopies, so that's why they are very useful for atrial arrhythmias. We cannot use them in ischemia. In ischemia, we cannot use. We cannot use it in heart failure. We cannot use. And we cannot use when we have a conduction defect. If we have, for example, an atrioventricular block or we have a bundle branch block, it isn't. We cannot use these drugs mainly because they are very powerful on blocking those sodium channel, and we can stop and go and have further conduction defects. So that is the 1C, and the next one will be the 1B. The 1B, we have some examples: lidocaine, mexiletine, also we have phenytoin. In this case, we have that this is the opposite, so those are drugs that are very fast in the onset and offset of the channel, so that means that they have small use dependence, so it means that when we give them, the slope of this phase 0 will be only, I'm going to put in another color here, will be only decrease in slower range. They also have an effect on potassium channels, but they have an effect that they enhance the current of potassium going out from the cell. So it means that they, in that case, the QT interval, that is the length of the action potential, will be decreased. The QT will be decreased. So here we have how it will decrease. And it's very useful for some kind of pathologies. In that case, the other way around, so we use it more in ventricular arrhythmias. It's more useful in ventricular arrhythmias rather than in atrial arrhythmias. So why do we use these drugs for? Well, usually lidocaine, for example, we use in ischemia. It's one of the most useful drugs for ventricular arrhythmias in the setting of ischemia, together with amiodarone. And we also have mexiletine. Well, mexiletine, we can use it in, for example, long QT, because it doesn't increase the. We can use in long QT. We mainly use it in type 3, okay? We can use in the other two, we mainly use in type 3. So those are the most utilities that we have. Okay, and finally we are going to have the 1A. We could say that 1A is like in the middle of the way of 1C and 1B. And which drugs do we have here? Well, they are drugs. We have disopyramide, okay, we have procainamide and quinine. Okay, in this case, because this is in the middle of the way of those two, they are like in medium. The velocity is medium. That means that the use dependence of the drug is like, well, in the middle of the way also. So, and they also prolong the QT. So that means if we represent them, because they have use dependence that is in the middle, we can bring it here in the middle of the way, and they increase the action potential. You have to be careful with this, because this increases the QT. It increases QT. Okay. So here, what do you use this for? We are going to use them both in atrial and ventricular arrhythmias, in both, because it's in the middle of the way of the other two. And we are going to use mainly disoperamide, because this disoperamide is special in the sense that it has some negative inotropic effect. Negative inotropic effect means that it makes the heart beat a little bit weaker. We use it for hypertrophic obstructive cardiomyopathy. You know, if we use a negative inotropic effect, it will decrease the gradient in the outflow tract, so it is useful, mainly if it is associated with atrial arrhythmias. So it is useful, and we use disoperamide in patients with hypertrophic cardiomyopathy, mainly if it is associated with atrial fibrillation. We use procainamide mainly for well-tolerated ventricular tachycardia, because it prolongs the refractory period. It is useful, and also because they block the sodium channels, we also use to unmask the Brugada. We have already seen it in the syndrome. We also use to unmask Brugada. With this purpose, we also use another drug that is called Achmalin. We have a type 2 or type 3 Brugada where we are not sure whether this patient has Brugada or not. We give this sodium blocker and we try to mask it and turn into type 1 Brugada. And finally, we arrive to quinidine. We can use quinidine for the treatment of patients with Brugada, syndrome. And someone we would say, why do you give a patient with Brugada? Brugada, you remember there are patients that have impaired sodium channel, a sodium channel blocker. Why? Well, it is just because they have the action in the action of quinidine in sodium channels is very weak, but they have shown to have effect on blocking those channels here. You remember they were the potassium transient channels that were the ones that were pushing down the action potential in patients with Brugada, and if we block them, the action potential will increase and we will have less problems. Anyway, we must say that we only use this drug in patients that already have a defibrillator but have a lot of shocks. Okay, now we are going to talk about the class 2 anti-arrhythmic drugs. Those are mainly the beta blockers, and in this case, the main channel that will be blocked will be the calcium channel. We are going to act in here. So, what do beta blockers do? They act both in the calcium channels that we have in the pacemaker cells here. So they will bring the slope down and will decrease the heart rate. They decrease the heart rate, and that is why many times we use beta blocker to slow down the arrhythmias, to bring the heart rate down, not to try to have an anti-arrhythmic effect. But they also act in those calcium channels over here, and that's where we can have the anti-arrhythmic effect. we can remember that sometimes we can have after the polarization, that can be either early after the polarizations and also delayed after the polarization, as the one that we can have in ischemia or CPVTs, or here the early ones in the long QT syndrome. For those, to avoid those spikes of calcium, then here we have the beta blockers that are useful. That's why we use beta blockers a lot in patients with long QT syndrome type 1, type 2, and also in CPVTs or in situations of ischemia or when we have a lot of catecholamines. We can try to guess the secondary effects of beta blockers by knowing where they act. We have those effects by acting in the beta-1 receptors. Those beta-1 receptors are mainly localized in the heart, so we will have to be careful with patients with conduction diseases. Any problem, any block, we have to be careful with patients treating with beta blockers. But they also block the beta-2 receptors. That means that we also have to be careful in patients with any problems in the because they produce in the lungs, they produce bronchoconstriction. We have to be careful with patients with COPD or patients with asthma, and they also are able to produce vasoconstriction because they act in the beta dose, they block the beta-2 receptors of the vessels, and they can also produce hypoglycemia. Because there's like a break in the neoglucogenesis of the liver, and they can induce hypoglycemia. So those are the main side effects that we can find with beta blockers. Then we are going to skip class 3 and we will go right to class 4, because they are pretty similar, you will understand. Class 4 are basically the calcium antagonists. Not all of them, only the non-dehydropyridinic calcium antagonists that are diltiazem and verapamil. Diltiazem and verapamil are the calcium antagonists. Here, I said that it's pretty similar because they also block, as with beta blockers, they block the calcium channels, and by blocking those calcium channels, we have the same negative chronotropic effect, and that's why we use those drugs a lot to slow down the arrhythmias. Well, they could potentially have anti-arrhythmic effect, but this anti-arrhythmic effect is different from the one of beta blockers. They are not useful in case, for example, of early or delayed after depolarization. We are not using them, for example, in situations of long QT syndrome or CPVT, because they are not useful. The anti-arrhythmic effect of calcium antagonists is more limited, and we only use them for some idiopathic ventricular tachycardias where the origin is in the outflow tract, and we are not going to use them in other kinds of ventricular tachycardias because they can also be promoted. So the side effects of the calcium antagonists are also different from the one of beta blockers, mainly because what they do is that they can also block the calcium in the smooth muscle cells that can be either located in the vessels. So here we have that with calcium antagonists we are going to have vasodilatation instead of vasoconstriction. This vasodilatation sometimes can lead to ankle swelling and or can lead to headaches, and also it can act in the smooth muscle cells of the gut, and then it can produce, for example, constipation. And another main difference between the calcium antagonists and the beta blockers is that while with beta blockers we can use them and it's also beneficial in patients with heart failure with low ejection fraction, we cannot give calcium channel blockers in patients with heart failure with depressed ejection fraction. Okay, now we are going to talk about the class 3 anti-arrhythmic drugs. Class 3. What all of them have in common is in class 3 is that they block, in that case, the potassium channels are the ones that are going to be blocked. Okay, here we have several drugs that we are going to go one by one. The first of all will be sotalol. Sotalol is a beta blocker, so we can apply the same rules as we mentioned with the class 2 drugs, because it also acts with calcium, blocks the calcium. But also sotalol also block this IKR channel. Okay, IKR channel. So the way that the class 3 drugs are going to try to avoid the arrhythmias is by increasing the refractory period, acting in this part of the trapezoid, trying to increase the refractory period and in that way avoiding the arrhythmias. So here what sotalol does is that block this IKR and it increases the refractory period. Here we must say that it has a property that is called the inverse use dependence. As you might remember, in the class 1 drug we had what is called the use dependence. So it means that the more that we use the channel, the more effective is the drug. Here we have the opposite. So that is called the inverse use dependence. That means that the less that we use the channel, the more effective is the drug. And it's what happened here. Sotalol, because he's a beta blocker, it brings the heart rate down. So with a lower heart rate, we will have that the channels are going to be used less. And when they are less used, because we have inverse use dependence, the refractory period, the action potential will increase. In the end, what does it mean that we have an inverse use dependence with sotalol? That it is going to increase the QT interval a lot. So when we put a patient with sotalol on sotalol, that we mainly use sotalol for atrial arrhythmias. When we put a patient on sotalol, we have to be careful with all the things that we have with beta blockers, but also we will have to be careful with the QT interval. Okay, so we also have other drugs, that is dofetilib. Okay, this is what does it blocks the same channel. The potassium channel doesn't have the beta blocker effect, but also because it blocks these channels and has the inverse use dependence, we are going to have the same problem as with sotalol. We have to monitor the QT and interval very often. Then we also have ibutylib, pretty similar than the dofetilib, but we give it intravenously, and also apart from blocking this potassium channel, will also block a little bit sodium channel. Okay. Another drug in the class 3 of anti-arrhythmic drugs is called bernacalant. In the class 3, so it also blocks the potassium channels, but very ultra rapid potassium channels. So it is given intravenously. It blocks the potassium channels, the ultra rapid potassium channels, and is very effective, and we use it for atrial fibrillation. With recent onset atrial fibrillation, we give it intravenously. Okay, this is like we can group these 3 drugs of class 3 drugs, and then we are going to have another 2 of class 3. One is amiodarone. We use it a lot because amiodarone have it not only blocks potassium, but also is able to block sodium, is able to block calcium, and is able to block the beta receptors and also alpha receptors. So it acts in every side of the trapezoid. That's why amiodarone is very useful, and we use it a lot because it's very effective on every single. It doesn't matter whether it is an auricular or ventricular arrhythmia. Amiodarone is very useful. The problem is the side effects that amiodarone has, because it's very lipophilic. It's very lipophilic. Amiodarone accumulates and stores a lot in the body. It also has in the molecule some iodine. So amiodarone can store in the body and can produce, it can store in the skin, can produce photosensitivity, also can store in the eyes and can produce corneal problems, because it's this iodine molecule that can produce some problems in the thyroid, and also can produce problems in the lungs with pulmonary fibrosis. So the problem with amiodarone is that we have to be very careful if we use it for long term. We have another similar drug that is called dronedarone, that is pretty similar to amiodarone, try to act in the same things, but it doesn't have iodine in the molecule, and is also less lipophilic. We only use dronedarone in certain kinds in atrial fibrillation right now, and what there are some problems is that one side it is less effective than amiodarone, and the other side we cannot use in patients with heart failure. Okay, finally we are going to talk about another drugs that have recently been included in the classification of Bach and Williams. We could say that it is like an update of the classic classification of Bach and Williams of anti-arrhythmic drugs. We have also to mention ibabradine. Ibabradine, we could say that it is a new class 0. Ibabradine what does it blocks the current, the IF current, and by that way it decreases the slope and it decreases the heart rate in sinus when we are in sinus rhythm. The next one will be ranolazine. We could say that ranolazine is categorizing 1D, a new 1D class. Ranolazine really what does is that it blocks a late current of sodium. Currently, ranolazine it is not used as anti-arrhythmic drugs, but it is used as anti-anginal drug, because when we inhibit the entering of sodium here, there is less of calcium going inside the myocyte by this sodium-calcium interchange. So by the entrance of less calcium in the cell, it has the anti-anginal effect. So the next drug will be isoproterenol. Isoproterenol will be in the class 2B. What isoproterenol does is like a catecholamine. We know that catecholamines both enhance the channel of calcium rather in the myocardial cells, promoting an inotropic effect, and also in the pacemaker cell with a positive inotropic effect. So we could say that isoproterenol is a pro-arrhythmic drug, and in fact we use it very often when we perform electrophysiological studies to try to promote the arrhythmias. There are some cases in which isoproterenol can have we are going to say that it is acting calcium, can have anti-arrhythmic effect, and it is, if you remember, when we studied the after depolarization, the early after depolarization, usually those early after depolarization are promoted when we have low heart rate. So when there is, for example, a situation where we have a polymorphic BT triggered by this early after depolarization, what is called the Torsade de Pointes. It's a typical polymorphic ventricular tachycardia where we have the QRS complex are like going from one place to another, twisting around the isoelectric line. So we have that when we have this arrhythmia trigger, isoproterenol is useful because it increases the heart rate and can terminate this tachycardia. Also, we can have another one that is atropine. Atropine is classified, could be classified in the 2Z. Mainly atropine, what it does is that it blocks the receptors of the muscarinic receptors of the acetylcholine. So we know that acetylcholine will decrease the slope by blocking these calcium and sodium channels and enhancing the potassium. So with acetylcholine we will do the opposite, so we will increase the heart rate by this kind of vagolytic effect. Then we have digoxin. Digoxin is proposed to be in the 2D. Well, digoxin has very different effects. We already know that it has a positive inotropic effect because it blocks the sodium and potassium pump, and so a lot of sodium accumulates inside the cell. By this interchanger, the sodium will go out and will bring calcium in, giving the positive inotropic effect. But also, digoxin promotes the parasympathetic nervous system, so it will due to the effect of acetylcholine, it will bring our slope down and will have a parasympathetic effect. The next one will be adenosine. Adenosine could be in the 2C, anti-arrhythmic drug. What adenosine acts in some particular receptors of adenosine. What adenosine does is that mainly block in the pacemaker cells. It blocks the calcium and also the IF channels, and it also enhances the potassium channel. So in the end, bring our slope down and decreases the heart rate. It is very useful, adenosine, because it mainly affects the AB node. So when we have a re-entry tachycardia, we have already talked about that. Those re-entry tachycardia and the AB node take part in the circuit, maybe because it's an atrioventricular reentrant tachycardia or it's an accessory pathway, we can give adenosine to stop the tachycardia. Okay. Then we have another one that is nicorandil. Nicorandil is could be in the third class of antiarrhythmic drugs. Is in the third B, mainly because nicorandil is blocking some potassium channels. Currently, as it happens with ranolazine, nicorandil is being used as an anti-anginal drug. And finally, we are going to talk about some drugs we have already mentioned, that is flecainide and propafenone. We already mentioned them because if you remember, they were in the class 1C, but they can also, apart from class 1C, because they block the sodium channels, they can also be classified in the class 4, they call the 4B. Why? Because they seem not only to block those sodium channels, they also block these ryanodine receptors. The ryanodine receptors, as you might remember, are the ones that are in the sarcoplasmic reticulum, and they are there because when they sense that there is calcium coming in, they release more calcium. We have sometimes problems in those ryanodine receptors, they are not okay, and there is a leak of calcium and could produce those delayed after depolarization that we have. So flecainide and propafenone block these ryanodine receptors and avoid this leak of calcium. That's why recently these drugs are being used for the CPVT.